So my next guest speaker is Dr. Nada Hamad, is a staff specialist bone marrow transplant clinical and laboratory haematologist at St Vincent's Hospital, where she's also been the director of the Haematology Clinical Trials Unit. She's the chair of the New South Wales Bone Marrow Transplant Network, chair of the EverQ Haematology Reference Committee, and secretary of the Bone Marrow Transplant Society of Australia and New Zealand, and senior lecturer at the University of Sydney. Very busy. She completed 2 postgraduate fellowships in bone marrow transplant and lymphoma at the Princess Margaret Cancer Centre in Toronto, and she works at St Vincent's here in Sydney. Thank you.
Thank you. Hello, everyone. I'm going to try not to rush. I just have to be somewhere. So please feel free to interrupt to ask questions, just so that we don't lose track of the questions at the end of the day. And today, my job was to talk about transplant and lymphoma. So it's a very big task because transplant is quite complicated. And what I wanted to do was really just demystify transplant, talk about the types of transplant so there's not too much confusion about transplant and lymphoma, and look at the indications and the outcomes in transplant in lymphoma. I'm going to point you to some helpful resources and then talk about some questions and answers if you want. Sorry, just a second. There's some problems with the technology. So I'm just going to go through the history of bone marrow transplant just very briefly. A long time ago, in the 1960s, it was thought to be a plan for the atomic bomb, essentially. If the atomic bomb went off and people suffered bone marrow failure from nuclear toxicity, the thought was this could be a way of saving people's lives. And from the 1960s, there has been incredible amounts of research, amounts of information from all the patients that went through transplants. The improvement in the outcomes in transplant are very, very clear because of some of these developments. And now we're coming to the age in 2019 now, where we're incorporating not only supportive care measures with transfusions and antibiotics and antivirals and antifungals to protect people going through transplant, but also including things like manipulation of the stem cells, harnessing the power of the transplant itself to reduce the risk of relapse and disease. So bone marrow transplants sound really gruesome, and if you Google bone marrow transplant, you might see some gruesome things. So my advice to you is don't Google it. It's not, the term itself is confusing because it says bone marrow in it, and you have these images of somebody going into your bone marrow and pulling it out. But that's not what we do. Technology has made it very simple for us these days. Essentially what someone does, this would be a donor, they would sit down on a chair, they get an intravenous drip or a needle in their vein, as you can see over there. The blood gets removed, spun in a machine. The machine removes the stem cells and gives the patient back their blood. So it's quite an easy thing to do for a donor. It is not something that we do in theatre very often. We sometimes ask donors to give us their actual bone marrow, and we take them to theatre, and we do use needles to pull the bone marrow, but that's very rare. So most of the time, it's not a big arduous task for the patient who's donating their own stem cells to themselves or donating stem cells to someone else. So that's what it looks like. This brings me to the types of transplant, which can be very confusing because everybody assumes a transplant is a transplant, but there are 2 types of transplants. One is called an autologous stem cell transplant, and an autologous stem cell transplant is something that you do for yourself. You get your own stem cells, you remove them, you put them in a fridge, and we use them at a later date. The idea is that these stem cells can be used to save you when we give you chemotherapy that is extraordinarily toxic to your bone marrow, but also knocks out the cancer or the lymphoma. Does that make sense? So we give you chemo that will eradicate the lymphoma, but when we do that, the bone marrow is very sensitive and it gets knocked out as well. So what we do is we take your stem cells that you gave at an earlier time, prepared previously, and we infuse it back into your system and allow that to grow back again into the bone marrow. And so it's a rescue situation. It's not really a replacement of your bone marrow. And this is very important because the autologous stem cell transplant has a different aim. So we're not really doing anything with the cells. We're just trying to rescue the system back into normal health. And the toxicity or the complications from that transplant are significantly less than if you had a transplant from someone else, which is called an allogeneic stem cell transplant. The complicated treatment is the allogeneic stem cell transplant. This is a slightly more labor-intensive, patient-intensive type of process. And so allogeneic stem cell transplants are transplants from someone else, whether it's a relative or a completely unrelated donor. The reason these transplants are useful is because they do two things. It has two effects. One, it allows for high-dose chemotherapy to be given, and then we can rescue the system like we did before. We talked about in the autologous stem cell transplant. But also, those immune cells from the donor will have an effect against your lymphoma or your cancer, because you are seen as foreign. These cells are seen as foreign, and that immune system can fight them and try and get rid of them. So this is called the graft versus lymphoma or tumor effect. Now, I often say to people, allogeneic stem cell transplants are like a deal with the devil. There are a lot of strings. The intention is to cure the cancer or to cure the malignancy with this transplant. However, that comes with complications. We talked about the donor's immune system trying to get rid of the cancer. In the same vein, it will fight the person who's received those cells. So the patient themselves can suffer something called graft versus host disease, which can be very mild and very manageable, or it can be severe and eventually can lead to death. So the problem with allogeneic stem cell transplant is that we have to balance those two effects. We have to make sure that the patient gets a little bit of graft versus leukemia or tumor or lymphoma effect without really dying from graft versus host disease. That's why it's a very specialist type oriented procedure, and it requires a lot of hospitalization. It takes a long time to be in hospital, to get out from hospital. It takes a lot of visits to make sure that patients are monitored very closely. And so the toxicity from the transplant is quite significant. It's improved over time, but it is significant enough that one has to ask themselves whether they're prepared to go through a procedure like that. And so there's a lot of counseling that goes beforehand when we decide to do allogeneic stem cell transplant. As the Bone Marrow Transplant Society Secretary, I would be remiss in not mentioning the Australian Bone Marrow Transplant Recipient Registry. This is a registry that collects data from all patients who have received a transplant, and it collects information about how well they did in terms of their survival, what complications they had in terms of graft versus host disease, and in general, it allows us to see how we're doing as a country in terms of delivering this kind of specialized care. We also feed into registries internationally. It allows us to compare how things are going in Australia versus other countries. And I'm very pleased to say that in Australia we do a very good job of transplanting patients. So you can see over time in this graph, this is the days after transplant. This is the transplant-related mortality, as in the death related to the transplant itself and not the cancer. And you see if your patient has an unrelated transplant, these are the blue lines. The survival, the incidence of transplant-related mortality, or the incidence of death or dying from the transplant, is roughly in the 20% mark. So out of every 100 people, we lose 20 just because they went through the transplant itself within the first 300 days. The same happens with patients who have autologous stem cell transplant, but at a much lower rate. You can see we're looking at 2% versus 20%. So autologous stem cell transplant is very different to allogeneic stem cell transplant. Donor types. So patients are always asking about who can be their donor. And some people are very lucky. They have a large pool of donors available to them, whether it's lots of siblings or they're from a genetic background or ethnic background that lends itself to a lot of people in the donor pool. So Caucasians tend to have more donors than patients who have a very complicated ethnic background, mostly because there's more people in the donor registry, from Caucasian people from the donor registry. Siblings, each sibling has a 25% chance of being a match to a patient. So the more siblings you have, the more likely one of those might be a match. Sometimes you're really lucky and your 2 siblings are a match, and sometimes out of your 10 siblings, there's no match. It's just luck of the draw. Unrelated donors are part of a international pool of donors in a registry, and when a patient needs a transplant, we can do a search based on their genetic makeup and their haplotype to see if there's a match out there for them internationally. And then we ship over the cells by airplane and try and sort it out that way. Haploidentical transplants are really taking off. The research has shown that you can transplant patients that are not a full match to their donor. So you don't have to be a 10 out of 10 match. You can be less than that, and so your children can do it. Children are always only half a match of their parents. And so fundamentally in the past, we used to think, well, that's not possible because the patient would have a lot of graft versus host disease and would potentially die from the graft versus host disease because the patient's not the donor's not a match. But now we've developed a lot of strategies to minimize the graft versus host disease and to improve the outcomes of patients having haploidentical transplant, and that's on the rise. So a lot more patients are getting transplants from their parents or their children. We used to try and use umbilical cord blood, but that's a very difficult procedure because umbilical cord blood is a minuscule amount of blood. It's so tiny, and to try and transplant an adult with cord blood requires a lot of cord blood. So you need multiple cord blood donors to be able to offer a transplant of that kind to an adult. And so it becomes complicated. So we do a lot less of those now. We talked about the patient sitting at the end of on a chair getting their blood spun out. That's called a peripheral blood stem cell transplant. And that's one of the sources we use, which is the most common source we use. Whether it's an allogeneic transplant or your own transplant, that's what we try and do. This source has a higher risk of graft versus host disease, but we accept this risk because it's much more practical to try and get donors to donate peripheral blood stem cells, and we also offer strategies to minimize the graft versus host disease risk. We can do it from bone marrow, and we tend to use bone marrow when we don't really want any graft versus host disease, which tends to be in patients who don't have a malignancy. We actually do want the graft versus host disease because that fights off the cancer that we're trying to cure. So it's not usually used in patients who have a malignancy. We tend to try and use peripheral blood stem cell transplants. And we talked about umbilical cord blood, and that comes from frozen cord blood from banks. So this is just a graph of the current trends. This is international trends from the International Bone Marrow Transplant Registry. And you can see that autologous and allogeneic stem cell transplants are both on the rise. There was a time where, one peaked and the other didn't. And this time here is an unusual time where people started doing them for all sorts of things, including breast cancer, and then realized, oh, that's not a very good idea. There's a lot of problems when they stopped doing them for breast cancer, and then we normalized them. So they both started going up along each other. So, talking about non-Hodgkin's lymphoma specifically, because that's what I think most of you are interested in, it is the second most common reason we do an autologous stem cell transplant. So we do them in myeloma and we do them in lymphoma. There are various subtypes of lymphoma, as you heard from Jane Estelle earlier, and so the transplant role is different in each subtype of lymphoma. And you can see here the number of stem cell transplant recipients in patients over the age of 16 and their probability of survival depending on the type of lymphoma. Roughly very similar, except the T and NK cell lymphomas, not so great, 29% at 10 years. Mantle cell lymphoma, about 40%. Diffuse large B-cell lymphoma, about 40%. Follicular, about 50%. So it's not a cure. Not 100% of patients who get the autologous stem cell transplant do well. And there's many reasons for that, and we can go into that later. So I'm going to start with diffuse large B-cell lymphoma. It's about a third of the cases of lymphoma. You probably heard that from Jane. And we use transplant, particularly autologous stem cell transplant, in the relapsed refractory cases, in patients who their disease has come back after chemotherapy, and the idea is to cure these patients. We would only use an allogeneic stem cell transplant in fit patients who relapsed even after an autologous stem cell transplant. But that strategy is not a good strategy. And I'll explain from these graphs here. So these are patients who've had autologous stem cell transplant. The probability of survival over years. You can see that in patients who have been sensitive to chemotherapy, they don't do too badly. We're looking at a 75% survival long term. Patients who are chemo resistant the disease is declaring itself as a disease that's not going to respond to high intensity chemotherapy, whether you rescue the person or not. So we're looking at about 40%, 30% long term. So for these people who don't survive, we move on and consider doing an allogeneic stem cell transplant. Chemosensitive disease, still long term about 50%. Chemo-resistant, pretty bad, roughly between 20 to 30% survival. So allogeneic stem cell transplant is not really the answer in diffuse large B-cell lymphoma. We think we might save a few, but in reality the data is not there to support it. There are now more promising treatments, particularly CAR T-cell therapy, and I'm sure Ken Micklethwaite, who's sitting right there, is going to talk to you about. But we're trying to find ways to salvage these people without putting them through the process of a transplant. Follicular lymphoma, it's again a third of the cases in autologous stem cell transplants, and we use autologous stem cell transplants again in these patients once they're relapsed or refractory. So they've had chemo, it's not working, or they have relapsed after treatment. Some centers will do an autologous stem cell transplant just to prolong the period of time a patient is alive rather than cure. And some people will do an allogeneic stem cell transplant as a potential cure, because you could potentially cure patients who have not been cured otherwise with the graft versus leukemia or lymphoma effect. So you can harness the immune system of the donor in an allogeneic stem cell transplant to cure the follicular lymphoma. Similarly, here are the same graphs, chemosensitive, chemo-resistant. These patients, the probability of surviving. You see that the curve is actually a bit better than we saw with diffuse large B-cell lymphoma, and you're looking more towards the between 60 to 80% survival. There's always a difference between chemosensitive and resistant disease. Allogeneic stem cell transplant, much better than diffuse large B-cell lymphoma. You can see that we're looking at longer term survival, or around 75%. So we do have much better outcomes with follicular lymphoma than with diffuse large B-cell lymphoma. Mantle cell lymphoma, it's thought to be an indolent lymphoma. An indolent lymphoma usually means a lymphoma that grows slowly. But sometimes mantle cell is very aggressive. It can grow quickly, it can be very hard to treat. And in these patients, in this particular disease, we consider autologous stem cell transplant in the first line setting. So we don't use it when the patient relapses or when chemo is not working. We use it up front in the beginning. So we give patients chemotherapy with R-CHOP or maxi-R-CHOP, higher doses of CHOP, alternating with a high DAC type protocol, which is a drug called Ara-C, and then we use a BEAM stem cell transplant. The BEAM stands for the chemotherapy regimen, which is a high level type chemotherapy dosing that will knock your bone marrow out, knock the lymphoma out, and then we give you the stem cell transplant after. And the overall response is 95%. So 96% of patients will respond, 54 will go into complete remission, and the average or the median overall survival is about 12.7 years. So patients can live a very long time having received this upfront therapy. It's not curative, but it increases the duration of time where the patients are disease-free. And that can be a very good thing. To be alive for 10 years after, a procedure like a transplant is a big win. I don't think that's something to be, I think it's to dismiss easily. Now, allogeneic stem cell transplants are supposed to have a curative intent in mantle cell lymphoma, but we would reserve that for patients, again, who have relapsed after an autologous stem cell transplant, or the disease is not well controlled with standard therapy. And the reason being is that you can see here, these patients with an autologous stem cell transplant have very good overall survival over many, many years. And with an allogeneic stem cell transplant, the survival is much lower than an autologous stem cell transplant. There are some long-term survivals, but 50% survival, those odds might scare a few people off. And it has impacts on your quality of life, so we don't do it lightly. I'm just briefly going to talk about Hodgkin lymphoma. Most patients are cured by chemotherapy alone, so the 5-year progression-free survival is about 70 to 90% with just normal standard therapy. In patients who relapse or are considered refractory to first-line chemotherapy, we would find that autologous stem cell transplant will cure a significant number of those as well. So in refractory patients, overall survival at 5 years is about 40%, and in relapse disease is about 50%. So you can cure some people with an autologous stem cell transplant. There are newer drugs out there now that have improved those outcomes even more, and we would only use allogeneic stem cell transplant for relapse and patients who are not responding to treatment. I'm going to quickly go through why allogeneic stem cell transplant is so difficult. I'll talk you through what happens. Essentially, a patient comes and they say, look, I've got no other choices. I need an allogeneic stem cell transplant. And we say, all right, well, let's see if you have a donor. If you have a donor, well, that's great. Are you fit enough? Do you have any other medical problems that will complicate this procedure? Some patients do, and we have to manage those things. Some patients don't. And once you're considered fit for a transplant, well, then we would bring you in and do some tests, make sure we know what we're dealing with. We have to sit down with a psychologist, you have to sit down with a dietitian, a social worker to make sure this is all going to work. When you get admitted to hospital, it's expected that you'd be in hospital for at least a month. So it's a long time. And a month, it's not easy because chemotherapy has side effects. So a lot of patients will have early side effects from the chemotherapy. You would be expected to have an infection because when you get chemotherapy that knocks your bone marrow out, well, we've deprived you of all the things that protect you from infection. So your white cells that are there to help you fight infection, they're no longer there. And they're not going to be there until the bone marrow that we give you starts to go into your bone marrow and grow and regenerate. And that takes about a couple of weeks. So there's a couple of weeks of vulnerability to infection. And beyond that, when you do get infection, you can damage your organs. You can damage your liver, you can damage your kidneys, your heart, you might end up in the intensive care. And so it's a time of very heightened alertness in terms of monitoring patients very closely, very rigorously. Once your bone marrow regenerates and your white cell count is back, you're not out of the woods yet, because we still look for the risk of graft versus host disease. We give patients immune suppression to stop this graft versus host disease from becoming overwhelming. And if it works, it doesn't happen. And we're very good at minimizing graft versus host disease now, but if it does happen, it can be quite terrible. Patients can get severe skin rashes where the skin can literally fall off. And some patients can get very bad diarrhea that basically we're not able to catch up with the fluids that they're losing. And sometimes you can get liver function abnormalities that can be life-threatening, and kidney function abnormalities that are the same. So it's a lot of intensive medical observation and management of all the complications. We know that about 70% of patients will get graft versus host disease, whether it's the acute version or the delayed version. Not all of it is severe. 20% will get severe GVHD. And severe GVHD is a big problem because it takes time to treat and it requires a lot of immune suppression. When you suppress the immune system, we're actually suppressing the donor from fighting the lymphoma as well. So we're losing some of the benefits of the transplant. As far as long term, if patients survive the first 30 days in hospital and they survive the first 100 days of a transplant, the first 3 months are very difficult. There's a long period of time where you have to keep coming back into clinic just so that we can make sure that graft versus host disease is not affecting the rest of your organs, lungs, skin, eyes, etc. These side effects can be quite debilitating, so it's important when we discuss allogeneic stem cell transplant, we talk to the patients about their potential risk of developing these complications, the impact on their lives, their livelihoods. So young patients who are working full-time or have young children have to adapt to a potentially new normal for them where they may not be as functional as they used to be. So it's quite complicated with a lot of potential problems. That's not to say there are patients who a year out don't go back to full-time work and live normal, fulfilling life, but there are patients who struggle significantly, have a lot of complications that mean that their lives are very different after. In terms of resources, I would direct you to the Bone Marrow Transplant Society of Australia and New Zealand, We have a lot of patient information. We have a transplant guide for allogeneic and autologous and pediatric. And you can look at these are all the patient resources out there on the internet. We've selected the best that we have and put them on the one website. EVIQ is essentially it's a national program designed to make sure patients and doctors both have accurate information about chemotherapy regimens, whether it be side effects or how the treatment is delivered. And if you want any information about a particular chemotherapy regimen that your doctor's recommended, this is where I would recommend you go and look that up. There's patient information pamphlets and there's doctor information pamphlets, and they're very different and they're designed to allow maximum understanding of the treatments. In New South Wales, we have a bone marrow and transplant network where all the hospitals that do transplant participate in making sure the quality of our care is up to scratch. And it has a lot of patient information about the hospitals within the network, but also some of the information you saw about transplants in one of those other resources sections, as well as where to get even more information if you want to. And I think I made it in time. Just enough time for some questions.
Any questions?
Yes?
Thank you. That was really interesting. My brother's actually just gone into hospital for his allogeneic transplant after relapsing from his autologous stem cell transplant last year. He has peripheral T-cell lymphoma. I just wondered if you had any advice for, obviously coming out of that in the next couple of weeks will be important, but monitoring over the next year at home, just what the level of personal infection control and any guidelines that you have around that?
So there's a lot of guidelines about infection control on some of these resource websites. I think that's very important. I think it's important to ask your doctors or the transplant physician that's involved. It's different for everybody. Some people who have children, there's no way you can avoid your children who come back from daycare and school with all sorts of bugs. But general hygiene, with hand washing, making sure you're not, kissing and hugging people who have got a known cold or an infection. In the first 120 days, that's the time they're most vulnerable, but beyond that, patients have vulnerabilities to different things depending on the amount of immune suppression that they're on. So it's not a one answer fits all, but it's an important answer to ask on a regular basis depending on what treatments that you're on.
I have a little question about flu vaccinations. When is it safe to have flu vaccinations after transplant?
It is safe, and there is on the the Bone Marrow Transplant Network has a post-transplant vaccination schedule, because post-transplant you lose your vaccination, you lose your immunity in a sense, because we've immune suppressed you and we've given you a new immune system, so you need to rebuild that and strengthen that up again. So there's a very comprehensive vaccination schedule, and it includes the flu vax. So some vaccines are very safe to have post-transplant and others are not so safe, especially the live vaccines, because the patients are immune suppressed or not able to mount a reasonable response against the vaccine. So we would encourage you to get the card. There's a card that patients take to their GP, and the GP delivers the vaccinations at the correct time.
Where would family and friends go to get onto the donor registry? What's the best?
So the donor registry, if you want to be a donor, you can do that through the Red Cross. That's who in Australia manages the donors for us. You can be a blood donor and elect to be a bone marrow donor at the same time. So certainly if you wanted to be a donor, feel free to do it that way and encourage other people to do the same.
With the Red Cross on that subject, they won't take you as a bone marrow donor if you're over the age of 45.
That is a problem, but because we know that the older donors are not always the ideal donors, and I'm not sure if it's 45. I think it's 45 if you're not a related donor, but if you're a related donor, that's a different story. So if you want to be in the big pool for international donors, we like to have young, fit donors, and it's also because they tend to have less medical problems that can be problematic for the donor themselves. So asking someone with a heart problem and diabetes in their 50s to become a donor may not be a sensible thing to do. But certainly you can be an older patient and donate to your own family.
And what period to receive a transplant?
That's a very good question. So, to be honest, most centers.
Repeat the question.
Okay, yeah, sure. So what was the age cutoff to receive a transplant? A lot of centers have some hard rules about the age, but to be honest, most clinicians are quite sensible. So if a patient is 70 years old and can run a marathon, that's very different to a patient who's 50 years old and has heart failure, kidney failure, and liver failure. So you need to have good organ function and resilience to be able to receive a transplant safely. So no one would actually say a hard number, but in general, patients over 70 don't do as well as younger patients. In fact, the older you get, the harder it is to survive a transplant. There's no real cutoff. It's an assessment based on a case-by-case basis.
What about 75 and then weak because of chemo treatment?
Probably not. Yeah, it depends. If it was an autologous stem cell transplant, because they're not as hard to get through, some clinicians might consider it. If an allogeneic, that would not be reasonable.
It's the problem with having so many treatments beforehand.
In the case of allogeneic transplant failure, at the current stage, what are the options after that?
It depends on the lymphoma and the current treatments out there and the clinical trials available. So some trials will say, sure, we will take you after a transplant if you've relapsed and try this new drug. Others would say it would be unsafe to do so using this particular drug because it can compromise the safety of the patient, and so they're not included. Every lymphoma has a suite of new drugs available to them now, so it all depends on a case-by-case basis as to what kind of lymphoma you've got.
Just in particular, the newer immune therapies, obviously the fact that you've got someone else's immune system makes that.
It does make that very challenging because some of the immune therapies, I think you may be referring to things like pembrolizumab, and those sorts of drugs, they can actually make graft versus host disease very, very bad. So you can get really bad GVH after using those drugs. It's not to say that it's impossible. There's a lot of research going into how we might be able to utilize those drugs in the context of graft versus host disease, but in general, it's considered very, very tricky and very dangerous to do.
All right. There's some great questions there, and thank you so much, Nada, for it was a great coverage, and also where you can get information from as well from the internet, like especially EviQ. I use that religiously, and it has a lot of self-care information for patients as well, so I really highly recommend anyone can get on that site. So thank you so much, Nada, really appreciate it, your time and for coming along today.